Hello, everyone. Thank you for joining today's web interface support call for ACOs, group, and virtual groups. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone in the support call questions box, and CMS Subject Matter Experts will address as many questions as time allows. Also, to note, a recording in the slide deck from today's call will be posted on the QPP webinar library within the next 2 weeks. Now, I'll turn it over to Lisa Marie Gomez at CMS to begin.
Thank you. I want to welcome everyone and thank you for joining us today as groups, virtual groups, and ACOs prepare for quality reporting. Again, I'm Lisa Marie Gomez from CMS. Joining me on the call today are other experts who will share helpful information on the CMS Web Interface, quality reporting, and also answer your questions following today's presentation. Today's call will only focus on 2022 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS in general, or quality reporting, questions that may be outside of today's presentation. Today's slide deck, recording, and transcript will be available on the QPP webinar library within the next 2 weeks. Next slide, please. This is a disclaimer slide. This slide is about, so this information in this presentation is current at the time it is published, but I encourage you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program or the Shared Savings Program regarding any updated information. Next slide, please. Now I'm going to discuss announcements and reminders. Next slide, please. The CMS Web Interface will close at 8 p.m. Eastern Time on March 30th, 2023. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. 2022 is the final performance period for MIPS groups, virtual groups, and APM entities to report using the CMS Web Interface. Transition resources are available on the QPP Resource Library and the QPP Webinar Library. The CMS Web Interface will remain an available collection type only for Medicare Shared Savings Program ACOs reporting via the APP or the APM performance pathway for the 2023 and 2024 performance periods. Next slide, please. New resources. The materials from the March 8th, 2023 support call are now available on the QPP Webinar Library, so you may access those resources now if you would like. Next slide, please. The CMS Web Interface API is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. As a reminder, requesting another CMS approved reason is a way to skip a patient attributed to a measure during denominator confirmation. These requests are reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specification. Requests must be submitted through the CMS Web Interface and make sure to provide detailed information about why the patient should be skipped. It isn't necessary to request another CMS approved reason if there is an applicable denominator exclusion, if there is an applicable denominator exception, or if the patient is not qualified for the sample. The following requests will be denied. Care 2 falls, screening for future fall risk. Request to skip a non-ambulatory patient. Denominator exclusion for non-ambulatory patients was removed. The exception is that all patients are screened for fall risk. Next slide, please. Submit your request for other CMS approved reason during the last days of submission of the submission period may cause your request to not be processed. Requests submitted after Wednesday, March 23rd, 2023, actually Thursday, March 23rd, 2023, may cause your request not to be processed prior to the close of submission. So we encourage you to submit your request as soon as possible. So again, we're requesting that you submit your request for other CMS approved reasons as soon as possible. Again, we want to ensure that you have the ability to have a response for your submitted request. You can learn more about how to submit other CMS approved reasons by reviewing the 2022 CMS Web Interface User Guide, starting on page 52. Now I'm going to turn the presentation over to Angie Stevenson to review frequently asked questions that arose during the question and answer session from the March 8th, 2023 CMS Web Interface support call. Angie?
Thanks, Lisa Marie. Hi, this is Angie from the PIMS team, and I'll review the questions on the next slide from the March 8th support call. The first one is for age determination, and this would be applicable to all 2022 CMS Web Interface measures. The question was, how is age assessed for measure eligibility? For example, the 2022 CMS Web Interface HTN2 measure has a patient eligible age range of 18 to 85. If a patient is 85 at the start of the measurement period, but turns 86 during the measurement period, is that patient eligible for sampling for the HTN2 measure? The answer is for all measures that include an age range in the sampling criteria, a patient must be in the age range on both the first and the last day of the measurement period. For lower age limits, patients are sampled based on their age at the first day of the measurement period. In the case of the MH1 measure, which is a little bit different, that would be on the first day of the denominator identification period. For the 2022 measurement period, this is a patient's age as of January 1st, 2022 for most measures, or in the case of MH1, it is November 1st, 2021. For upper age limits, where applicable, patients are sampled based on their age as of the last day of the measurement period. For example, the patient's age as of December 31st, 2022. For example, in regard to the HTN2 measure, if a patient turns 86 during the measurement period, the patient isn't eligible for sampling into the measure. And you can find more information on the CMS Web Interface sampling eligibility by referencing the link here for the sampling methodology for 2022. And that can be found on the QPP resource library. Next slide, please. This question is for the Prev 12 preventative care and screening for depression and follow-up plan measure. Can a depression screening tool score of 0 be considered negative for the Prev 12 measure? Based on the guidance within the specification, the clinician needs to review, verify, and document whether the result was negative or positive in the medical record. This medical information can be documented by the clinician in a way that best communicates and supports the patient and outcome of the assessment. However, the measure doesn't require documentation of a specific score, just rather the results of the normalized and validated depression screening tool used are considered positive or negative. The expectation is that the organizations follow the measure specifications and document all the components. CMS can't provide specific feedback regarding whether or not documentation in a patient's medical record would meet the intent of the measure. The Prev 12 measure specification references are below here, and it says the results must be verified or reviewed, verified, and documented by the eligible professional in the medical record on the date of the encounter to meet the screening portion of the measure. Screening tools are the name of the age-appropriate standardized depression screening tool utilized must be documented in the medical record, and the depression screening must be reviewed and addressed by the provider filing the code by the date of the encounter. Next slide, please. This question's also on Prep 12. Does a certain condition, intellectual disability, impairment, Alzheimer's disease, dementia, autism, etc., does that qualify a patient for a denominator exception? And the answer is the specification doesn't define denominator exceptions by specific diagnoses. Additionally, the coding document doesn't contain codes for all potentially applicable reasons for not screening a patient for depression. The expectation is that a reason for not screening the patient would be contained in the medical record. If the patient qualifies for the measure and there's medical record documentation that the patient wasn't able to be screened for depression due to their diagnosis or condition, for example, intellectual disability, impairment, Alzheimer's disease, dementia, or autism, etc., then it would be appropriate to select the denominator exception. For example, this denominator exception could be reported if there's medical record documentation stating the screening wasn't performed due to the progression of the patient's dementia, rendering them unable to answer the screening questions. Okay, thanks everyone. I'll now hand things over to Carrie Barrows to review the CMS Web Interface reports. Thanks.
Great, thank you, Angie. Hi, my name is Carrie Barrows. Good morning, good afternoon, depending on where you are in our country. I am on the Web Interface product team, and I work with Lisa Marie and others. And today I am going to provide a high-level overview of the reports that are available in the CMS Web Interface. Next slide, please. So these three reports are always available. The data confirmation report, so you can access a report during and after submission. During the submission period, the report serves as a real-time receipt of the data that CMS has received to date. And then it really is the same thing after submission. It's just if you wanted to go back in and double check what you had done, you can certainly do that using the data confirmation report. There's a measure rates report. When you use the measure rates report, you see an in-depth breakdown of your progress on each of the measures for the performance period. And you'll see in the next slide or so how you can get to these reports, but that's the second report that's always available. And the third report is the activity log. It's kind of like an audit trail. It records the different type of activities that people on your team may have performed in the CMS Web Interface in respect to your submission or trying to get information in on your beneficiaries and reporting against those. So 3 reports that are always available: data confirmation, measure rates, and activity log. Next slide, please. There's a couple of reports that are conditional in nature. You'll only see the skip requests or data irregularity reports if you've submitted a skip request for another CMS approved reason or have submitted data that seems inconsistent. So the skip request report lets you track the progress and outcomes of any requests that you've made to skip a patient from a measure for a reason not specified in the measure specification. For example, other CMS approved reason. And the data irregularities report identifies irregularities at the measure and the patient level. So at the measure level, when a measure's been reported with a 0 denominator due to skips and or denominator exceptions, we're going to see that as a data irregularity. And at the patient level, when inconsistent data is reported within a measure, or measure data is reported for a patient who isn't qualified for the sample or the measure. Those are a couple of scenarios that you'll see for the data irregularities report. So again, these 2 reports are conditional. You have to have either submitted a skip request or submitted data that is deemed inconsistent. Next slide, please. So the important piece here, how do you get to these reports? So the reports are accessible from the left navigation bar. So when you're logged into QPP CMS Web Interface, you are able to navigate via the left navigation bar to an option called View Reports. And once you're in View Reports, you'll always see the 3 reports that are always available: data confirmation, measure rates, and activity log. It's important to note that not all of the reports are available for download or printing. For example, activity log is not available for downloading or printing. The other 2, measure rates and data confirmation, you can definitely download and print those. You can always view the reports, though. That's the important piece. Also, you can access data irregularities and measure rates by clicking on View Progress. So in the same left navigation, there's a View Progress option. That's where you can go to see data irregularities and measure rates as well. Next slide, please. So how do you get more information about the reports? You get that information by using the resource library. It's an excellent place to visit if you're looking for information. So you can get to the resource library a couple of ways. You can get to the user guide in a couple of ways. So you can get to the resource library from Resources, Resource Library. And once you're in the resource library, you'd scroll down towards the bottom of the page, and there's a section where you can input web interface so that you're searching specifically for things related to web interface. You can select the performance year that you're interested in. Here we're selecting 2022. And once you do that, it will present to you a list of documents related to web interface. You'll scroll down a little bit and you'll find the 2022 CMS Web Interface User Guide. This is an excellent resource, and I would recommend going there first. If you've ever got a question, it will likely answer your question for you. And if it doesn't, as mentioned previously, feel free to go to the support help desk and ask the question, and we'll gladly find the answer for you. So another place that you can get to the user guide, the web interface user guide, is from within the application itself. So in the lower right-hand corner of this slide, we're in a section called View Progress, where I just mentioned you can also get to data irregularities and I can't remember what the other one was now, but the other one that you can get to, measure rates. That's the one I'm thinking of. You can get to measure rates here. But also in kind of the middle of the page, underneath the 3 cards, you can get to the actual user guide right from within the application. And you click that link, it takes you right to the guide. So it bypasses going to resource library and choosing the year and so on and so forth. Every year we update that link so that it's putting you into the correct performance year version of the document. So from QPP Resource Library, or if you're logged into the CMS Web Interface, you can get to this great user guide and hopefully get your questions answered. If anything, again, is still not quite clear, you can always submit a request to get some additional help. Next slide, please. So with that, I'm going to turn it back to Angie, and she's going to lead us out with frequently asked measure questions.
Hi again. Thanks, Carrie. Next slide, please. Let's see. So MH1, the depression remission at 12 months measure, is our first batch of frequently asked questions. The intent of the measure is for adolescent patients 12 to 17 years of age and adult patients 18 years of age and older with major depression or dysthymia, and an initial patient questionnaire 9, a PHQ-9, or a PHQ-9 modified, PHQ-9M, a score greater than 9 during the index event to reach remission at 12 months plus or minus 60 days after the index event date. The MH1 measure allows use of telehealth. The PHQ-9 or 9M administration doesn't require a face-to-face visit. Multiple modes of administration are acceptable: telephone, mail, e-visit, email, patient portal, iPad, tablet, or patient kiosks kiosk would be acceptable. Patient remission, a follow-up PHQ-9 and PHQ-9M result less than 5 may be determined during a telehealth encounter. Next slide, please. First question is, what documentation is necessary to support a diagnosis of major depression or dysthymia? And this is in the measure specifications, and it tells you that you can confirm the diagnosis of major depression or dysthymia using any of the following methods: a diagnosis code on the encounter or problem list, regardless of the vendor assigned description of the code. Words major depression, major depressive disorder, dysthymia, dysthymic disorder, pervasive depressive disorder, DSM-5 term for dysthymia is pervasive depressive disorder. So that would need to be on the progress notes or problem lists and can be used to confirm the diagnosis. Additionally, in paper records, the description of depression may be used with the option to confirm by billing code. An active diagnosis of major depression or dysthymia is defined as a diagnosis that's either on the patient problem list, a diagnosis code description listed on the encounter, or is documented in the progress note indicating the patient's being treated or managed for the disease or condition during the denominator identification period. Next slide, please. Question 2 is, can you explain how to determine the index event date? For that, you would first verify the patient has an active diagnosis of major depression or dysthymia during the denominator identification period. For this measure, which is November 1st, 2020 to October 31st of 2021. Then look for the date of the first instance of a PHQ-9 or PHQ-9M greater than 9 during the same time period where the diagnosis is also present. And that would be considered your index event date. The patient must have both the diagnosis and the PHQ-9 or 9M greater than 9 during the denominator identification period to be confirmed for the denominator. Refer to the step-by-step submission guidance and measure confirmation flow in the 2022 AMH1 CMS Web Interface Depression Remission at 12 months measure specification. Question 3, is it acceptable to calculate the PHQ-9 score during abstraction if the score isn't totaled in the medical record? The answer is no. If the score isn't totaled in the medical record, you must select no when asked if the patient had one or more PHQ-9s or PHQ-9Ms administered during the denominator identification period. Documentation of a follow-up PHQ-9 or PHQ-9M with a score of less than 5 is also required to determine if the patient achieved remission for the numerator. Next slide, please. Question 4, can you please clarify the timing used to identify denominator exclusions? For denominator exclusions that require a specific diagnosis, the diagnosis must be active any time prior to the end of the patient's measure assessment period. The index event date marks the start of the measure assessment period for each patient, which is for a period of 14 months. That's 12 months plus or minus 60 days from the index event date. Patients who were permanent nursing home residents anytime during the denominator identification period or the patient's measure assessment period would be excluded. Question 5, will a PHQ-2 score of 0 during the measurement assessment period count toward the numerator, or is a PHQ-9 required? The answer is a PHQ-9 doesn't meet the intent of the measure. You must use a PHQ-9 or PHQ-9M, and all 9 questions must be answered to have a valid summary score. Next slide. And now we'll review the PrEP 5 breast cancer screening measure. The intent of the measure is for women 50 to 74 years of age to have a screening mammogram for breast cancer during the 27 months prior to the end of the measurement period. Prov 5, use of telehealth. Documentation of screening for breast cancer may be completed during a telehealth counter. The medical record documentation must include the date the screening was performed, the type of test, and the result finding. Next slide, please. Okay, question 1. Does a partial mastectomy count as a denominator exclusion? The answer is a unilateral mastectomy only counts as a denominator exclusion if there is medical record documentation also of a mastectomy of the other breast. If only one breast is present, a unilateral mammogram on one side must be performed on the remaining breast. Question 2, the description in the Prov 5 measure specification states women 50 to 74 years of age, while the initial population states women 51 to 74 years, which is correct. The patient isn't considered eligible for the denominator until age 51, but mammograms received beginning at age 50 can be used to satisfy the numerator. The look-back period allows for a mammogram during the measurement year, the year prior to the measurement period, and a 3-month grace period for a total of 27 months. Question 3, is it acceptable for the patient to report previous receipt of a mammogram? Yes, as long as documentation includes the date, type of test, and result or finding, that would be acceptable. Documentation of normal or abnormal is acceptable for the results. Next slide, please. And question 4, how is CMS handling gender identity with regard to quality metric inclusion? Generally, CMS considers the patient's gender at birth for inclusion in the denominator. If there is an instance where a patient is sampled for the measure, but you don't believe they should have been, maybe they were born a male but identify as or have transitioned to a female, we suggest submitting a request for another CMS approved reason to skip the patient. CMS will evaluate each request on a case-by-case basis. In the instance a patient's demographic information is incorrect, it can be fixed within the web interface. Note that any demographic information you change in the web interface doesn't get reported back to Medicare patient enrollment database. So you should encourage your patient to contact the Social Security Administration directly to have such information updated outside the web interface. And that wraps up our questions today. And I'll turn things back over to Lisa Marie Gomez at CMS to complete the presentation. Thank you.
Thanks, Angie, so much. Next slide, please. So as I discussed, these next few slides will outline the available CMS Web Interface resources. So right now, we'll go to slide 27. So these slides, these are the resources that are available on the QPP resource library, and we encourage you to review these documents if you have questions on quality requirements and measures. And then so here are all the resources that you may need for your ability to complete and successfully report all requirements for the web interface. Next slide, please. This slide outlines all of the resources relative to the CMS Web Interface support calls that we've had over the course of the last several months. And they can also be found on the QPP webinar library, but we've posted them here for you to have them all in one place. Next slide, please. This slide outlines transition materials if you're transitioning to another collection type. So as we noted earlier, groups and virtual groups and APM entities that reported through MIPS using the web interface, the 2022 submission period is the last submission period in which the web interface is available to you all. And so transitioning to another collection type would be something that you all be working to. So we posted the resources for the transition materials also here within this slide deck. And they're also available within the QPP resource library and also the QPP webinar library. Next slide, please. This slide outlines resources that are available for the shared savings program. So we encourage you to review the materials available here for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Now I will turn the presentation over to Olivia to begin the Q&A portion of the presentation. Thank you.
Great, thank you, Lisa Marie. And yes, now we are going to start the Q&A portion of today's webinar, and you can ask the question two different ways. One can be through the Q&A box, and we have seen some folks already submitting questions, so thank you for that. And you can also ask a question through the webinar audio. So to do that, you would just raise your hand. You should see the raise hand button at the bottom of your screen, and we will unmute your line so you can ask your question. And just to kick us off today, we have a few questions in the Q&A box. The first one reads, can claims data be used as a receipt of receipt of record, for a flu vaccine received and reported for audit?
Hi, this is Jamie. Thanks for this question. For Prev 7, it's the only instance where numerator-specific data are pre-populated. So note that the influenza immunization data that aren't pre-populated for all patients, that this data may not be pre-populated for all patients that are ranked in Prev 7. And it's just because we may not be able to find that specific administration of the vaccination within the claims data. So if influenza immunization data has been pre-populated for a patient, it doesn't need to be validated. The group, virtual group, or APM entity, including shared savings program, ACO, won't have to provide medical record documentation for pre-populated influenza immunization data. However, if influenza immunization data are not pre-populated, the group, virtual group, or APM entity, including the shared savings program, ACO, should refer to the patient's medical record to determine if an influenza immunization was administered in accordance with the web interface measure specification, and then document those findings within the web interface. The influenza immunization data that's obtained from the medical record is subject to supporting that documentation or that reporting within the web interface. Thank you.
Thank you. And the next question says, I have submitted a CMS skip request. Can I document it in the web interface that the measure was missed, screening not performed now, and have that change if and when CMS approves the reason, or do I need to wait and not document anything until I receive CMS's decision?
Hi, this is Katie from the PIMS team. So in terms of the skip request, once that decision is issued, it is final. But I would look, Carrie or someone from the product team, if you can address if there's any functionality issues with continuing to report on a patient while a skip request is actively open.
Oh, this is Carrie. So a skip request has been entered for the patient for a measure. I would have to go in and take a look at that before I could give a firm response. Let me see if I can get logged in and check on that.
And if the person who asked that question can put your skip request number in the Q&A, we can kind of check on the status of that request as well. Sometimes they just take a little bit longer to research, or there might be some internal back and forth or additional information needed. So we do process them fairly quickly as they come in, but sometimes there are instances where they just require a little bit more research. Thank you.
Great, thank you. And then Carrie, a question for you that came in. This person just wants to confirm that there's no submit button in the web interface portal, meaning whatever data we leave as of 3/31, will that be the final score?
Yeah, that is correct. So as long as you don't have any open errors, and you are seeing what you expect to see from the number of measures completed, as long as you've uploaded your information or have manually gone through and completed it, you should be good to go. And anything that's in there as of that 8 p.m. Eastern time frame when we close the interface on March 31st, you should be good to go.
Yep, and just another caveat, make sure that as you're entering information, that you've completed the fields, because if you don't complete them, it won't send. So just make sure everything is filled out and is available.
Yeah, and so there should be tabs that you can see, and one of them is incomplete. If you keep an eye on that, just to make sure that you have in fact entered everything and completed a patient, and then completed the measure, that's a good thing to keep an eye on.
Okay. And Angie, a couple of questions for you. One was a request just to go back over the slide from the beginning about depression screening. Was that
Yes.
slide?
That'd be slide 11, I believe. And I just wanted to bring it back up and for this person, and maybe they, I don't know if they have another question they want to enter in the chat box or live call. But I thought we would go back to it and have a look. That the first question is if a score of 0 on a tool can be considered negative, and the answer was no. The measure really isn't looking for a score, but it does have to be reviewed by the physician at the time of the screening and document whether the physician interpreted those results as negative or positive. So I'm not sure what the question was, but that is the gist of it, and all components that are in the specs, and of course this should be documented in the medical record.
And Oren, can you go back to slide 11 just for a moment?
Oh, I'm sorry. I thought you had. I was.
Thank you. So yes, if there's any other follow-up questions to this slide, please go ahead and submit them through the Q&A box.
Thank you.
Thank you. And we can go back to that Q&A slide. And then Angie, just another follow-up question for you on Prev 6. It says for Prev 6, patient reported in chart that their colonoscopy was from years ago. Does that fulfill the requirement, or do we need an actual age?
So to be current for colorectal cancer screening, the specifications say that the colonoscopy would have to be, I'm sorry, I had it right here and I'm missing it now. The colonoscopy would have to be during the measurement period or during the 9 years prior to the measurement period. So we would at least need a year documented for when of the last colonoscopy, as well as results of any kind of results, or normal, abnormal would have to be there. But we would need the year in order to ensure the colonoscopy was current. Thanks.
Thank you. In the next question, can you please restate the web interface transition requirements to CQM, ECQM for APM entities?
Yes, this is Kara with the ACO POS team. For groups, virtual groups, and APM entities reporting traditional MIPS, the 2022 performance period will be the last period that they will be submitting through the CMS Web Interface. Beginning with 2023 performance period, these groups, virtual groups, and APM entities will need to use alternative options for collection and submitting their quality data. For Medicare Shared Savings ACOs, the 2024 performance period will be the last period for reporting CMS Web Interface, and ACOs will need to use alternative options starting with 2025. There are resources on the QPP resource library that groups, virtual groups, APM entities and ACOs can look to get more information about that transition and other options. Thank you.
Thank you, Kara. We did receive a question on DM2, and it says, for the question, was the patient's most recent blood pressure reading documented during the measurement period? What is considered the measurement period? Is it 2022 measurement year or the first 6 months of 2022? And then a follow-up, it says also for the question, does the patient have a documented hypertension starting before, et cetera? Does the diagnosis just have to be in the patient chart at any time or during the first 6 months of 2022?
Hi, this is Carol from the PIMS team. So I'm assuming this is hypertension 2, controlling high blood pressure. And based on the guidance within the specification, in order to confirm your denominator eligibility for 2022, your medical record documentation just needs to support that your patient has an active diagnosis of essential hypertension starting before and continuing into or starting during the first 6 months of the measurement period, which is of 2022. So it is not necessary for your patient to have a visit in the first 6 months of the year if you're able to confirm that based on the medical record, the patient had a continuation of the diagnosis and that it carried into 2022. So they can have it before the year, and it just has to show that it has continued into the year, or they can be diagnosed in the first part of the measurement year.
Right, and the next question, just for clarification, someone is asking, what did you mean when you said pre-populated wouldn't have to provide documentation for the flu vaccine?
Hi, thanks for this follow-up question. What that means is that when you received the tool itself with your sample, if there was claims data that indicated an administration of the flu vaccination, it would have been represented within that tool, that space. Therefore, if it wasn't pre-populated, it means that we were unable to find it within the claims data that came from your sample. And that's why we would need that medical record documentation to ensure that the administration of the vaccination was completed. I hope that helps. Thanks.
Great, thank you. And the next question says patient had myalgia and muscle pain in 2006, went on a statin. In 2022, PCP coded T46.6X5D adverse effect of antihyperlipidemia in anti-arteriosclerotic subsequent encounter. Would that be acceptable for the exception? If so, why or why not?
Hi, this is Katie from the PIMS team. So use of this particular exception requires that it is documented to be active during the performance period. So an active diagnosis is is defined as a diagnosis that's either on the patient's problem list, a diagnosis code listed on the encounter, or is documented in a progress note indicating the patient is still being treated or managed for the disease or condition at any time during the measurement period. So from the information provided in the question, it appears that only the intolerance is still active, but that the myalgia isn't more recently documented. So you would need to be able to support that the intolerance due to myalgia is the reason for the denominator exception and is active during the measurement period. Thank you.
Great, and just transitioning over to the phone lines, it looks like we do have someone with their hand raised. Jennifer, we have unmuted your line and you can ask your question. You just may need to unmute on your end as well. Oh, looks like her hand is lowered, so we will go back to the Q&A box. One question that we just received: when and where will this presentation be shared? We are interested in the links for the transition to CQMs and ECQMs. Specifically, we are looking to understand the decile points under CQM.
Hi, so this is Katie. I just wanted to address this really quickly, all of the transition documents are currently posted on the QPP resource library. If you use the search tool on the resource library and search transition, you will find a transition guide for the CMS web interface, including getting started with ECQM and CQM reporting. Additionally, if you navigate to the webinar library and also search for transition, the previous webinars going over transition away from the CMS web interface are available, along with the previous support calls that we've had for 2022, and links to all the resources are available within those previous support calls as well.
Great, and then just shifting back to the phone lines, Sandra, we have unmuted your line. You can go ahead and ask your question.
Thank you so much. I kept on raising my hand, but I wasn't sure you saw it. So anyway, thank you so much. I actually have two questions and a comment. So my one question is back to Prev 12. Last year, or even the year before, the response around the PHQ tool in particular, if it was 0, because a lot of the docs were saying 0 can only be negative. Why do I have to document that in my note if it's 0 and I'm saying PHQ is 0 or whatever? Understanding that for Prev 12 they want negative or positive. Years ago, though, a couple years ago, the answer was if it was 0, then we could accept that. So I'm curious that it seems like this year we're not able to accept it. So has there just been a change in philosophy, or are we not carrying guidance from years prior to the same measures forward? That's my first question.
Hi, this is Katie from the PIMS team. So I think we are, we're advising based on the language that's in the measure specification, and the language does state that the clinician needs to review, verify, and document whether the result was negative or positive. How specifically that's documented in the medical record can be up to the organization or clinician, but that specific piece is within the measure specification stating that interpretation is necessary.
Right, and so, I mean, it's been the same language for a few years now, and again, it was different response on these calls. And again, is it safe for us to say, if the measure hasn't changed, that prior guidance that has been given on these calls is carried through to the next year? Like, I understand if the measure changes, we would have to look at it differently, but if it hasn't, is that safe to say, or is that not true? Is it year by year? So anything I've learned prior, I can't assume is going to be applicable for this year.
So, I think in particular, as the measure specs are updated each year, that it would be beneficial to review for the guidance. And, you know, there are certain things that don't necessarily carry over. Having a score of 0 documented in the medical record, I know at least for the past couple of years now, we have been saying that we can't speak specifically to your organization's medical record documentation or how you document. We can only advise on the language and the requirements that are within the measure specifications, and that your medical record documentation would need to support the information reported.
Okay. But the actual, forget about this particular measure. When you give us guidance and we say, okay, great, and next year the measure has no changes except for maybe the look back period or the, you know, performance year, does the guidance still apply in the new year? I mean, it seems to me like when we're asking these I'm reading the guidance. I'm absorbing the guidance. I think I understand most of it. And then I attend these calls and I get more information, which clarifies very often, which is wonderful. But now I'm feeling like I'm not sure that what you're telling me now would apply to next year if the measure doesn't change substantially. I think I'm just trying to understand, you know, where like this added knowledge is going to be beneficial. Like, do you get what I'm saying? Like, all these questions are because people are reading the guidance, but are just getting the guidance read back often as our reply. But then there's times that there is some, you know, kind of clarification that really makes good sense, and we'd like to be able to say next year, if this measure is just the same, you know, we'd be able to know that that is still the same guidance. Is that not the way that you all see it?
Hi, this is Lisa Marie Gomez of CMS. I can definitely hear your frustration, and I just want to note that the information that we give you is based on the way the measure specs are developed. And I know that there has been cases, particularly with questions about, you know, a score of 0 on a test in terms of assessing whether or not someone has depression. I know there's been a lot of questions about that. And I will just say that when we provide information, it's not to say that we change our responses. I think that's what you're assuming, that we're changing our responses from year to year. And I will say that our responses do not change unless there's a change in the measure. There may have been ways that we're communicating the information a little bit differently, but we're not changing. And I think, as Katie noted, specifically for some of the measures, we as CMS, we're not going to be able to say and know all the ins and outs of how an organization does their specific workflows or what they do internally. But what we can do in general is provide a global response that can help. And I know that there's been frustration again with, you know, when there's, but I think, as Katie noted, and can we go to the one slide? I think it's slide 11, I believe. But on that slide, and I think, again, what we want to highlight is that what's most important, and I will specifically say this, I think the key part here is that, and again, because we don't know, and I know that in some instances, some workflows require that, oh, a clinician sees a score of 0, and someone's like, can that be assumed that that's 0? Again, I think this is what's really, really critical that we have here on the slide, is that the clinician needs to review, verify, and document whether the result was negative or positive in the medical record. So you can't, so here, whether it's 0, 1, 2, or 3, even if it's 0, again, there has to be documentation whether the result was negative or positive in the medical record. And I know there's been frustration about this, but again, I think we're providing as much information that we can. And again, this is in the event that, let's say there is an audit, and I don't want to get into audits, but let's say someone is auditing and there is no documentation for what the review is. How are we able to know that? And I think that's why we're specifying that they have to be documented, whether the result was negative or positive. I don't want to go on to this because I know there may be other questions, for
I
us
get
to
it.
review,
Thank
but I'm
you.
just wanting to let you know that for CMS, we want to provide as much information as possible. But again, we go with what's in the measure specification. And I know that it's just important that that's documented in the medical record. Again,
Okay.
I thank you for your question.
All right. So my next question is specifically around breast cancer screening. And so very clear to me, we're looking for females. If they've, not had bilateral to unilateral mastectomies, they need to have a mammography or some screening. In our organization, we had 2 males. They were born males. They identified as males, and they're males. We put in requests for CMS, other approved reasons to skip them, and they were denied. And I'm just not understanding why they would be denied, number one. And then how are we supposed to handle documenting the response on those 2 folks, because they're not female, so they don't qualify for the measure. So I'm a little curious on how we need to handle documenting on that. I was very surprised. Years past, we've had them, approved. We've gotten our code and been done with it. And this year, 2 different submissions came back denied.
Hi, so this is Katie. Generally, when we resolve those tickets, we put a description, at least for those, the Prep 5, if the patient is a male, saying why it's denied. And the reason is because the patient demographics themselves can be updated within the CMS Web Interface. And those instructions for doing so are on page 28 of the CMS Web Interface user guide. So once you actually go in and update the demographics for that patient, it will remove them from the measure. So in this instance, a CMS, another CMS approved reason isn't necessary because you can correct that on your side.
But even though they come through as a male to us from CMS, we still have to go in and what? I mean, like they came through as a male. They weren't identified as a female to us.
Hi, this is Jamie. I'm going to go ahead and jump in here. Most likely the information that's being provided on the claim form is where we're generating that output into the tool. So I just wonder if with somewhere within the medical record or when they were, well, when they're billing that information out, whoever's generating that information onto that claim form would be the basis of how we sort of set up the sample within that tool, but others please chime in to clarify if needed.
Okay, that makes more sense to me, but thank you. And I'm sorry to, take up your time, but it was very confusing to me because it wasn't clear like why we would get a denial for a male, a real male, And then my last thing, and I said I had just sort of a comment, I guess. And, I've attended these for years now. I think they're very, very helpful. The one thing that I think would be extremely helpful is if they started at the beginning of quality season. And like, for example, today, a lot of this really great information, a lot of us are done or almost done, or, would have been great to have some of this guidance earlier on. And I'm just wondering if for maybe next year, that could be something that's considered. And thank you for all of your time because it's been very helpful.
Great, thank you for your feedback. That's helpful, thanks.
Okay. We will give it a couple of minutes if folks do have additional questions. It actually looks like we did just receive one for you, Katie. If a patient has an allergy listed to a statin and that allergy list is reviewed or confirmed during a visit in 2022, does that count towards the denominator exception?
Hi, so yes, an allergy to statin medication is an applicable denominator exception for 2022 Prev 13. So as long as you have documentation supporting that it was active during the measurement period, it would be appropriate to use the exception.
Great, thank you. It doesn't look like we have any additional questions, so we'll give it another minute or so. If you do have a question, please go ahead and submit that through the Q&A box or raise your hand.
And this is Lisa Marie with CMS. We posted the transition resources in the chat, so I just wanted to highlight that we posted the PDF documents and also the YouTube videos with regard to the transition webinars that we hosted last year and also recorded them last year, but they're still applicable even though they're recorded last year. Again, I just want to provide those resources for you as you transition to a new collection type for those of you who need to prepare for the 2023 performance period in which you will start reporting another collection type. And if you have any questions in addition to transition, please do not hesitate to reach out to the Quality Payment Program Service Center and submit any questions there, and we'll be able to provide any information or answer any questions that you have with regard to transitioning to a new collection type.
Thank you, Lisa Marie. And Katie, a follow-up question for you that says, is statin intolerance an exception for Prev 13?
So the 2022 exception for Prev 13 and intolerance alone was removed, and the exception is for patients with statin-associated muscle symptoms or an allergy to statin medication. So if the intolerance is related to either one of those, if there's something to sort of tie it together, then it would be acceptable to use. But if it's just intolerance alone with no other supporting information, it wouldn't. And we do recommend taking a look at the measure specifications. They're available on the QPP resource library. And you can download those and review each specification with their associated denominator exclusions and exceptions.
And just shifting back over to the phone line, Sumita, we have unmuted your line, so you'll have to unmute on your end, but then you can ask your question.
Hi, can you hear me?
You sound a little bit faint. I don't know if you can
Okay.
get closer. Yes, that sounds better.
Awesome. Just had a quick question around the hypertension measure, the HTN2 measure. If they had like if a patient has multiple readings in a day, on the same day, and do we take the lowest systolic and the lowest diastolic, even if they are not taken at the same time? For example, if a patient had two readings, one is 135 over 71, and the other one is 136 over 70, would we take the 135 from the first reading and 70 from the second one?
Hi, this is Carol. Yes, that is correct. And that is, I think, located on page 10 of the spec. So yeah, if you've read that, that is correct. That's how you do it on the same day.
Okay, awesome. Thank you.
Yeah, you're welcome.
Okay. We will give it another minute or so. If you do have a question, please go ahead and submit that through the Q&A box. But we did just get one more request. Miriam, we have unmuted your line, and you can go ahead and ask your question.
Hi, thank you. My question is about the colorectal cancer screening measure. I know that there is an exclusion for patients that have had a history of colorectal cancer, but if they are still receiving colonoscopies, do we have to take it? I mean, I know it's not an exception, it's an exclusion, but the patient is still actively getting colonoscopies.
Hi, this is Angie. So give me just a second. So you are saying the patient qualifies for a denominator exclusion?
Yes.
And, oh, I see. With the
but still
diagnosis.
does have current colonoscopies. So we would
Right.
like for her to fulfill the measure since she does, but
Right. So with exclusions, denominator exclusions, if the patient meets that criteria, then you must remove them from the denominator because they weren't intended to be in the population for the measure. I mean, it's good that she's probably still having, follow-up and all of that, but she would be excluded right up front because it's an exclusion. The only time you would go ahead and, if the patient meets the denominator, then you look for the quality action. But this patient doesn't meet the denominator to begin with because they are excluded. Does that make sense?
It does. Thank you.
You're welcome.
Okay, and as a reminder, please go ahead and submit a question if you do have one through the Q&A box, or go ahead and raise your hand, and we'll give it just another minute or so. And one question for you, Deb, a follow-up question for HTN2. Are readings taken during an urgent care visit included if they are the most recent reading?
And yes, this is one that I believe was answered also by Carol last couple of weeks ago. So just in case I get any part of this incorrect, Carol, please step in and make sure to correct me. But hypertension 2 does include urgent care coding. And so you would need to go ahead and include that blood pressure reading. Thank you.
Great. Well, it doesn't look like we have any more questions at the moment, so we will turn it back over to Lisa Marie to close us out.
Great, thank you. I want to just thank everyone for joining us.
Sorry, Lisa Marie, real quick. Just wanted to go back to the question that we received around the skip request. You can change the designation for your skip request and report on the patient. And once you change it from basically no other CMS approved reason to yes, it will then allow you to report the information for the patient. Sorry, back to you.
Great, no, thanks, Stephen, for that. And if you have any other questions, not necessarily relating to the web interface and reporting for the web interface, please submit your question to the Quality Improvement Program, or if you have questions specific for an ACO, please submit your question to the email address for the ACOs. And again, I just want to thank everyone today for joining us actually over the last several weeks, and for us to be able to be with you and answer any questions that you have. As you know, we have posted all of our resources or support calls that we've had the last several weeks to the QPPR webinar library. So please go to those resources for any information that you have with regard to any information that we've covered over the last several weeks. Again, I want to thank you all so much for joining us today, and we hope you all enjoy the rest of reporting for 2022 submission period. Again, enjoy your day and take care. Thank you everyone for joining us. Thank you. Bye-bye.